attach this chordae tendineae to the ventricular walls. So when you go in and you go into the lab and you look in a cadaver, these walls of the ventricles are very rough and very convoluted. They're very complex muscular structure. But they have these little strings, they look like little, just these little kite strings coming off the papillary muscles attached to the valve structures that help the valves function properly during systole. Last septation event that occurs, you have to divide, all this time these ventricles are forming, this outflow tract here, the aorta, the pulmonary trunk, is a common tube. It's just one tube. So you have to separate that into a pulmonary trunk and an aorta. And the way it does that is through this generation of these spiral shells. So if you look at a cross section of this early stage, you're looking at about 40 days or so. If you look at a cross section at this point, you see these little shells starting to develop on either side of these tubes. Eventually those shells meet each other and fuse, and it divides that common tube into two tubes. But it does it in a spiral fashion so that this tube is reaching left ventricle, and this other tube here is reaching right ventricle. And they kind of spiral around each other. When you look in the cadaver, the aorta and the pulmonary trunk are spiraled around each other. This is why. But the pulmonary trunk has to go to the lungs. The aorta is trying to get to the arch so it can send out blood systemically. So now we've separated, with this septation, you've separated this common outflow tract. It's also called a truncus arteriosus. This common outflow tract into two chambers, into two tubes, and an aorta and a pulmonary trunk. So at this point, you have a heart that has 4 chambers, 2 atria, 2 ventricles, has functional valves, and has a common outflow tract. It has a outflow tract separated to an aorta here, and a pulmonary trunk. So now you have pretty much a mature heart, but it needs to go through all this histogenesis, become more robust in its myocardium, and the chordae tendineae have to become stronger in order to reach function in a normal adult. There's 2 other valves that need to be developed. There's a valve in the aorta that stops blood from moving into the aorta during systole, then backing up into the ventricles after systole. This is called the aortic valve. They're termed semilunar valves here. There's one in the aorta and there's one in the pulmonary trunk. These develop as this common outflow tract divides into two, into a aorta and a pulmonary trunk. Some of the edges at that point of division begin to lengthen and broaden and generate these valve cusps. In these valve cusps, blood is pumped through into this chamber. The pressure in this chamber during systole, this pumps, blood moves into this area on the distal side of the valve. This relaxes, so now pressure here is higher than pressure here. It pushes these valves closed, they just slap closed, and now it's a one-way valve. They're passive structures, they have no movement, whereas the atrioventricular valves have those chordae tendineae that's pulling on. So this is a passive structure, but it allows blood to move in a one-way fashion during beating of the heart. And this is important because it's just all about efficiency, all about moving the blood through. Okay, so the hearts, we've generated a heart. We also have to generate these inflow tracts and outflow tracts. The outflow tract, we saw this truncus arteriosus, we just subdivided into an aorta and a pulmonary trunk. It also has to attach to all these aortic arches that form during early development as the formation of pharyngeal arches. This will all eventually be remodeled as carotids and structures in head vasculature. This inflow tract, you have oxygenated blood coming through the umbilical vein to the heart. You have 2 umbilical veins and 2 umbilical arteries. These umbilical arteries will persist, both of them. The right umbilical vein will eventually degrade and disappear. So now you only have one vein coming in from the placenta back into the heart. These vitelline veins are veins that were going out to the yolk sac. Eventually they'll detach as the gut forms properly. These will disappear. So in a mature umbilicus, you have 2 umbilical arteries, a left and right umbilical artery, but you only have one umbilical vein bearing oxygenated blood back toward the heart. These other veins and arteries are body wall veins and arteries. these cardinal veins, right and left dorsal aorta. You have superior and inferior cardinal veins. These are all providing blood to the body wall and the structures of the embryo, and also bringing deoxygenated blood back to the heart from those same structures. So common outflow tract here, common outflow tract here, aortic arches. These are dorsal aorta, so blood is pumped from the heart up into that common tract and out through those pharyngeal arches to the dorsal aorta. This will all go through remodeling during development, during embryogenesis. What started out as the first aortic arch over here, or actually up here, will persist just as a little piece of the maxillary artery in the head. Second arch, a little bit of it will persist as the pedal artery in the ear. So just very small components. The major one, the first major one, is this third arch. It will form most of the carotids. Common carotid all the way up to the external carotid and internal carotid. Fourth arch here will form a portion of the arch of the aorta. Sixth arch here, there's no fifth arch. Sixth arch here will form portions of the pulmonary trunk. So all this remodeling is going on as the heart is developing. So you go from this ordered structure to looks like a very asymmetric structure. The arch of the aorta here, pulmonary trunk here, carotids coming off the arch of the aorta. You see none of this anatomy, right? So you have no idea really what we're talking about. We need to reorder these classes. Inflow tract also has to remodel. You had coming in from the umbilicus, you had vitelline veins, you had the umbilical veins coming in from the body wall, you had cardinal veins coming in from the body wall. This portion right here of this developing heart tube is going to form the atrium. This is going to be the inflow tract of the heart. All of this will combine, coalesce into superior vena cava, inferior vena cava, and coronary sinus, draining the heart itself. So 24 days to 56 days, you have pretty much a mature vascular return to the heart that you see in the adult. So it's very, very quick. The blood going to the lungs through the pulmonary trunk returns to the left atrium through the pulmonary veins. In an adult, the pulmonary veins are carrying oxygenated blood. In the fetus, oxygenated blood came into the right ventricle from the placenta. It's already oxygenated. Only that small amount of blood that went to the lungs is going to return to this portion. These pulmonary veins starts out as this one little branch coming into the left atrium. Left atrium gets bigger and bigger and bigger and starts to overcome or starts to overgrow these branch points of those pulmonary veins. So eventually you have 4 openings of the pulmonary veins into the left ventricle. 2 from the right, 2 from the left. This is an adult heart. The right atrium has been opened up. You can see a roughened portion. This is called pectinate muscles here. This roughened portion is derived from the primitive heart tube itself. You also see a very smooth portion of the right atrium. The smooth portion is derived from that secondary heart field that came in from the neural crest cells that migrated in. And also you see the septum here. This is the fossa ovalis. This is that shunt, the foraminal valley that shunted blood from right to left in the atrium, now closed up. So if you go into the lab, open up the right atrium of the heart, you'll see pretty much this. This looks like a thumbprint on the septal surface of the atrium. Like I said, this can be patent in about 30% or possibly patent in about 30% of individuals. Fetal development or fetal circulation is very similar to adult circulation, except you don't need lungs and you don't need liver in the fetus. Well, you don't need liver for the same purposes that you use portal blood in the liver. So heart blood is oxygenated in the placenta, returns through as oxygenated blood through the umbilical vein. That umbilical vein goes straight through the liver. The liver kind of developed around this umbilical vein. Goes straight to the liver, but the liver really doesn't need to detox this stuff. It's already gone through maternal liver. It's gone through placental capillary beds, so it's fairly clean stuff. Things can cross, but I mean, it's already been taken care of as far as liver function is concerned. So this blood can bypass the liver, and it does that through this shunt called the ductus venosus. So it's just bypassing liver. Liver's still getting some of the blood. It requires some of the blood for proper development. But this oxygenated blood can bypass the liver, go into the inferior vena cava, and dump into the right atrium. As the blood exits that inferior vena cava, it's kind of directed toward the foraminal valley. So it's helped to shunt from right to left by the direction of blood coming into the inferior vena cava. So most of that blood, majority of that blood, moves from the right atrium to the left atrium through the foraminal valley. That blood then moves to the left ventricle, then out through the aorta, systemically to the body. Some blood does enter the right ventricle, goes out through the pulmonary trunk here, but that's still too much blood for fetal lungs to handle. So there's another shunt here called the ductus arteriosus. And this is a shunt that develops from pharyngeal arch 6 that shunts blood from the pulmonary trunk to the arch of the aorta. All right, so now you have this one shunt through the liver, another shunt from right atrium to left atrium, and then a third shunt from pulmonary trunk to the aorta. You're just trying to avoid the lungs with all this blood because it doesn't need to go there. It's already oxygenated. Blood that does go to the lungs, that little bit of blood that does go to the lungs, goes through the lungs, comes back to the left ventricle, left atrium, goes to the left ventricle, and then goes out to the aorta. At birth, you have to switch from this placental oxygenation system to use of the lungs, and it has to be instantaneous. So the lungs have to be ready to go, the heart has to be ready to prepare for that, and the circulatory system has to be able to shut down properly in order to switch from a fetal circulation to a normal circulation. So child's born, takes his first breath, these lungs increase in size, more blood can be shunted through, they fill with blood, more blood's coming back to the left atrium, pressure starts to increase in that left atrium, it pushes that little leaflet of the septum primum closed, and now the foraminal valley is now closed. Pressure will be maintained higher in the left atrium than in the right atrium from now until death, and that'll keep that closed. So now all the blood coming to the right atrium moves into the right ventricle. All the blood goes into the pulmonary trunk. Most of it goes out to the lungs. Some is still going through the ligamentum arteriosus. The body starts to, the high pressure, the high oxygen tension now because the child's breathing on their own. The child's not so hypoxic anymore. The high oxygen tension starts to produce prostaglandins that can contract those muscles in that ligamentum, in that ductus arteriosus, and now it contracts down and closes up and becomes a ligamentum arteriosus. This may take some time. It may take a couple of weeks. In some individuals, it never closes. It remains patent. So there's always a mixing of oxygenated, deoxygenated blood. As long as it's, at a low rate, it's asymptomatic. There's no problems in that. Ductus venosus will close over time once this portal system turns on. The umbilical vein will shut down because the umbilicus has been cut. There's no more blood coming through it. So this will all shut down, become ligamentous, and the ductus arteriosus, ductus venosus will also become ligamentous, and no more blood will pass through. So now the liver is functional, lungs are functional, all these shunts have been shut down, and now you have a left heart and a right heart that are separate from each other and acting on different systems. So what can go wrong? One is a atrioventricular septal defect, atrioseptal defect or a ventricular septal defect. Atrioseptal defects are very, very common, depending on the type. 1 in 100 to 1 in 10,000. Up to 30% of adults may have an atrioseptal defect in the form of a patent foraminal valve that you can push a probe through. Now that doesn't mean blood is passing, shunting from right to left. It just means that leaflet never fused. But 1 to 100 to 1 to 10,000, some of them may have very large septal defects. So now blood is shunting in a newborn, blood is shunting from right to left aberrantly, and now oxygenated, deoxygenated blood is mixing, and the child is in a hypoxic state. Depending how large it is, can really dictate a large level of hypoxia. So if it's a very large defect, this child is in distress. It needs to be addressed. But these septal defects, there's all these different kinds. There's one that's very low toward the atrioventricular region. There's one that's very high septal defect, and all of these have different rates of incidence. Ventricular septal defects here, 2 to 5 in 1,000 newborns. This is quite common. These ventricular septal defects, same kind of thing. Deoxygenated blood comes into the right ventricle, right atrium, moves to the right ventricle, ventricle contracts, tries to push it out through pulmonary trunk. Some goes that way, some also goes over to the left. So now you still have a mixing of oxygenated, deoxygenated blood. You still have a somewhat of an hypoxic state. There's these can be fixed. I don't know if I have a slide of this coming up. These can be fixed quite readily by stenting, by moving a tube through venous structure into the right atrium, into the septal defect, and either inflating a balloon or inflating a cage that can seal off the structure. So used to they have to go in and crack open the chest, go in and do all these repairs. Now you can do this either laparoscopically or through the stenting, and it can be done very easily and readily.
Is that the same thing as a heart murmur?
A heart murmur can be caused by multiple things. One is that you can have a foramen ovale, patent foramen ovale, so blood is kind of spurting through, and you can hear that. Other ones, you can have valvular problems that account for the murmur. A lot of children are born with a heart murmur that then disappears, and usually you can attribute that to foramen ovale. But a heart murmur that persists, or is, there's a lot of different heart sounds. One that persists or one that has specific characteristics, you may have to address it very quickly. Persistent truncus arteriosus. In this case, the atria is septated just fine, the ventricle is septated just fine, except the outflow tract stayed as one tube. In this case, the separation of that outflow tract is required in order to finish off that ventricular septum, that little membranous portion of ventricular septum. So if you have a persistent truncus arteriosus, you also have a ventricular septal defect. So now blood comes in, either right or left, and both chambers are trying to pump blood into this common chamber. Some of it goes to pulmonary trunk, some of it goes to aorta. You still have a hypoxic situation, a mixture of oxygenated, deoxygenated blood. How do you fix this? How would you fix it? That's exactly what you do. You go in, you create a septum. You can close this off mechanically. You can go into these and just separate that out, reattach it to the right ventricle, and you can correct that quite easily. Well, easily now.
When these sorts of corrections, they have to be done at birth?
Usually the children, depending on the defect, the children may be able to survive, may be able to stay alive, and with assistance, they can stay alive. So you may have some time to set it up, to map out what you need to do and go in. Sometimes the child's taken from birth because they're prepared for it. They saw this with ultrasound and with all their imaging, and you can go in and you can address it immediately. Transposition of the great vessels. Septation occurred in this outflow tract, except it didn't spiral. And now you have an aorta coming off the right ventricle and a pulmonary trunk coming off the left ventricle. Is this compatible with life? No, you have closed loops now. It's going out through the aorta systemically. Deoxygenated blood is coming back in. It's never oxygenated and just goes right back out. So you have closed loops on either side. The child will die. No oxygenated blood is getting to the tissues. What can keep the child alive is a second defect where the ductus arteriosus remains open. And you can address that. You can give agents and medications that can counteract the closure of that ductus arteriosus, keep it open so this child can still get oxygenated blood out through pulmonary trunk out into the aorta, enough for survival until you can address the situation. How would you fix this? Go to a simple way. Yeah. You just cut, switch it, and sew it back together. Everything's fine. Not everything's fine. It's not that easy, but that's what you do. tetralogy Fallot, 1 in 2,500. So not really that rare, but on the rare side. In this case, you have 4 defects. You have a pulmonary valve stenosis. Stenosis means a narrowing. So this pulmonary trunk is very, very narrow compared to normal. So this right ventricle has to pump really hard in order to get the blood to go through this little chamber here. So you get, because of that, you get hypertrophy of the right ventricle. The ventricle wall gets really thick because it has to pump against high pressure. Where they're used to is just pumping against lung pressure, which is quite low. A ventricular septal defect here, and what's termed an overriding aorta. The aorta has shifted to lie just above that ventricular septum. So now blood is coming from the right ventricle out of the left ventricle into the aorta and into the pulmonary trunk. The child is born hypoxic, starts to degrade rather quickly, but this is very common and very correctable. You just go ahead and correct each situation and the child comes out fine. Sean White, the big snowboarder guy, he was born with tetralogy Fallot. So very correctable, becoming a super athlete after that. Okay, that's it. Any questions?
Absolutely.
Remember, for the exam, I'll have about 4 or 5 questions that come off that PDF. Just read the